pleased to welcome Dr. Marcas Bamman, who will be speaking today on exercise as regenerative medicine and its impact on chronic disease. After earning a Bachelor of Science in Exercise Science from Kansas State University and a master's degree in exercise physiology from the University of Alabama, Birmingham, Dr. Bamman went on to receive his PhD in the Department of Physiology at the University of Florida College of Medicine. As a PhD candidate, Dr. Bamman traveled to NASA Johnson Space Center in Houston, Texas, where he conducted spaceflight-related research in skeletal muscle for nearly 3 years. Dr. Bamman went on to join UAB faculty in 1996 and is currently a professor in the Department of Cell, Developmental, and Integrative Biology and the director of UAB Center for Exercise. He is also director of the NIH National Resource Center for High-Impact Clinical Trials in Medical Rehabilitation. He holds numerous appointments here throughout the university and is a 2011 UAB Healthcare Leadership Academy graduate and a fellow of the American College of Sports Medicine. Dr. Bamman founded the National Exercise Clinical Trials Network, a 61-site network that spans coast to coast. He is internationally recognized for his scientific contributions in skeletal medicine, muscle biology, and medical rehabilitation, with research focuses in aging, Parkinson's disease, spinal cord injury, and end-stage arthritis leading to total joint replacement. He has served on over 30 federal grant review panels, including the NIH, VA, and NASA. We are excited to have him with us today. Please join me in welcoming Dr. Bamman.
Thanks so much for the invitation and for the nice introduction. Hopefully I can show you some data that will live up to a little bit of that. I appreciate you not divulging the years of all of those degrees. So I've been at UAB for a long time. When she said 1996, it always makes me think about actually how long I've been here. I moved here with a 1-year-old child who is now a junior at Auburn University, and she's 20. So been here a long, long, long time. So I think we've developed a program in the UAB Center for Exercise Medicine that can potentially touch many of you in this room, and some of you are already collaborating within the center. But really the center is focused on this very simple concept. How can we provide evidence-based research that will drive medicine and drive clinical care? It's not sufficient for any healthcare provider or anybody dealing with a patient population to look at someone and say, you should do more exercise. We need to define what that is. That's no different or that's no more effective than handing a patient a bottle of antihypertensive medication, whatever that med is, just handing them a bottle of a particular medication and saying, take some of these. Right? It doesn't work that way. So we're interested in helping to define doses that are optimal and safe and appropriate for specific disease clusters and populations, and that's really what the center is all about. So moving research into medicine, sort of a double usage of the term movement there. So these are my disclosures. We're always required to do this. There's no money in exercise. So the slide is blank. I always like to recognize a lot of important folks that help in a number of these studies and help lead many of these studies that I'll talk about. I'm only going to really talk about 2 studies, well, sort of 3 studies today, focusing primarily on 2. But over the years, we've collaborated with a lot of people at UAB. The reason why you see this particular group on the right is because these folks contributed enormously to both our work in aging as well as the work in Parkinson's disease that I'll mention to you. And many of these folks that are currently or formerly in my laboratory are in the room, and want to recognize some of them. So when I talk about the Parkinson's work, most of that work was accomplished by Neil Kelly, who's here in the front, is a pre-doctoral trainee. And when I talk about the future of Parkinson's research, at least in our hands, and a little bit of that preliminary data in the brain. That's Kimberly Wood, who's a postdoctoral trainee with Dr. Amy Amara on our training grant. And so those two folks contributed a lot. And when I talk about anything to do with exercise training, whether it be testing, whether it be training, whether it be the day-to-day management of these very complex and difficult clinical trials that we'll talk about, I always have to refer to Craig Tuggle, and he's here in the room. But Craig manages and supervises our clinical trials facility and essentially is responsible for the day-to-day operations of all of these studies. So I want to recognize Craig as well. Mike Steck, I'll show you some of his data. Mike has since left us and moved on to his postdoc. But anyway, all these folks have contributed in numerous ways. Outside of UAB, we have a couple of 2-site trials happening now. One in aging, and that's with Charlotte Peterson and Phil Kern at University of Kentucky. The other is just sort of getting underway in Parkinson's disease with the University of Virginia and Art Weltman and some of his colleagues at Virginia. So without going any deeper into that, let's jump right in. So I want to talk to you about exercise from a conceptual standpoint and its application to research in a very rigorous way in talking about dosing and how important I think dosing actually is in research revolving around exercise. We'll talk about response heterogeneity, and that's inter-individual response heterogeneity. Very important consideration. Absolutely no different than any other form of treatment. Those of you who prescribe meds, you well know that there is an inter-individual response heterogeneity to any given medication. That's why blood pressure meds are constantly changing, doses are changing, the target is changing. We're trying to find what works in an individual. So it's no different when you talk about exercise. And then we'll get into some aging research, some Parkinson's research, and maybe if I have time, talk to you about what I think is sort of the next step in the field. So regenerative medicine, I put that in the title. You've probably heard since around 2007 this very commonly used phrase now, exercise is medicine. That was coined by the American College of Sports Medicine. And it's become a national sort of public health initiative trying to engage not only individuals in the community, but also healthcare providers into adopting this concept called exercise is medicine. And they've gone so far as getting groups of physicians and departments at academic medical centers to sign on to this initiative and say, we endorse exercise as medicine. So the UAB Department of Medicine signed on to this several years ago, and many groups have since. I've inserted a word that I think is critical, and that's regenerative. And the reason for that is because as regenerative medicine is defined, it's very much defined as tissue renewal, organ renewal. It's the creation of tissues that provide, repair, replace, or restore a structure or a function that is either absent, or it's defective, or it's diseased, or it's damaged. Well, hopefully by the end of this 45 minutes with you, you will have a better appreciation for exercise as a form of regenerative medicine. When this concept is brought to one's mind, most of us think about introducing exogenous components to fix something. What is regenerative medicine in the minds of most people? It's stem cell therapy. It's gene therapy. It's bringing something in from the outside to fix a defective tissue or a defective cell type or a defective organ internally. But what I'm hoping to share with you are some data to indicate that all of our physiological systems respond to the demand that's placed on them. And if the demand is sufficiently high enough, we can actually activate a number of endogenous pathways, endogenous mechanisms that can very much serve in a regenerative fashion. So this is a summary diagram. I won't quiz you on it later. But essentially, this is demonstrating what's been shown over the last couple of decades in the exercise biology field, and that is exercise activates the proliferation and the release of stem cell populations, in some cases mesenchymal stem cells, in some cases tissue-resident stem cells, such as those located in skeletal muscle, those located in the brain, and so forth. And if, again, thinking along this idea, this very important, critical, I think, central concept that our physiological systems respond to demand. Place a demand on the system, things will respond. We can turn on the stem cell pools in a variety of tissues and organs, including those that are circulating and traveling to distal sites. And in the course of doing so, force adaptations in adipose, in bone, in the vascular system, in the central nervous system, as well as the peripheral nervous system, in the heart itself, and in skeletal muscle. And the list goes on and on. But it's important to think about this idea that we, in many cases, we have resident stem cells laying in wait. They need a stimulus. And this is one of those stimuli that can turn them on. So lots of pathways have been identified over the years that are either activated or downregulated by exercise. And this is just it's a complex diagram, but it basically shows you that exercise, in some sense, we could apply the term pluripotent, okay? Every organ in your system, every tissue type in the system has to adapt or respond in some way to this perturbation that we call exercise. And so that's very much dose dependent. And so we need to be thinking about the optimal dosing, and I'll get into that later. Let me just give you a few snippets of data from the recent literature, not from my own research, to demonstrate this concept of regenerative medicine. Okay, so this is a very nice paper just published last year from an Italian group, and essentially what they're finding is a very robust induction of stem cell proliferation that is impacting the hippocampus and learning and memory. And what they're demonstrating in this study is that there is a pool of neural stem cells that can undergo proliferation and become sort of immature neurons and advance on to hopefully more mature structures, more mature neurons, and that the proliferative capacity of these cells is very much activated or upregulated by exercise. So what they do? They exposed mice to 12 days only of free wheel running. Unlike humans, if you provide mice with a wheel, they will run on it. They will not hang their coat on it. Okay? They will run 5 to 12 to up to 15 kilometers a night if you give them the wheel. Okay? It's strain dependent, but overall mice are far more active than we are. So 12 days of exposure to running, and now the wheel is removed. So not only does wheel running double, or in some cases triple, the proliferative capacity of these neural stem cells, 90 days later, there's still a doubling in capacity for proliferation. And this is shown very nicely here. This is along the border of the hippocampus. You can see if it's green and it's a punctate sort of BRDU positive cell, that means it's actively dividing. And you can see this very robust impact of exercise. So this is not to suggest that you exercise for 12 days and stop for 3 months. But it is showing you the power and in some way introducing a memory in these cells that is long-lasting. So I think that's a powerful demonstration of a regenerative medicine concept. Let's move to the cardiac system or cardiovascular system. So post-MI, stem cell therapy has become actually quite popular. Or at least conceptually, the field is moving toward this idea of trying to repair infarcted regions of the heart. So here's a study, just came out a month and a half ago. Acute aerobic exercise increases essentially the effectiveness of exogenously infused stem cells. And I'll show you that. So this is a study. These are 12-month-old C57 black 6 mice. They have a mechanism with cryo injury, so freeze injury, to actually mimic an MI or kill off a portion of the left ventricle, and then have the animals experience some exercise training. And what you find is by tagging the pool of stem cells that is introduced exogenously, okay, more of those cells migrate, under the exercise condition, more of those cells migrate to the region of damage, more of those cells differentiate to begin to express cardiac muscle actin, okay? So not only do you have more of these green, fluorescent green positive stem cells migrating to the border of the damaged area, you also have more of them differentiating and actually contributing to the repair of this region of the heart. The end result of that is you don't have an impact on the infarcted area, and this figure is really just to show you that both the exercise and the non-exercised animals, when you do the freeze injury to the heart, you get the same size infarct. But what happens is exercise capacity is dramatically increased in those that experience the training. All right, peripheral ischemic arterial disease. This is obviously a disease of great import to the Birmingham area and our surrounding region. And in fact, it's relatively understudied, I would say, in terms of exercise-based intervention. But here is a model, again, of testing whether or not exercise has an impact on collateral artery growth in a model of peripheral arterial disease. So how do they create ischemia? They do this, again, it's an animal model, but by femoral artery ligation for a period of time, okay, and then tracking whether or not collaterals form and whether or not that translates into improved exercise capacity. They tested in the presence and the absence of a running intervention. Again, this is very, very recently published. The nice thing about this study is they show a robust exercise effect, okay, on the perfusion capacity of the leg. But they also explore mechanisms. And in this study, they demonstrate quite nicely that if they essentially deplete the availability of macrophages that can help support this repair process through nitric oxide signaling, then that essentially takes away the exercise benefit. And if they transplant bone marrow-derived monocytes that are iNOS deficient, so these cannot make nitric oxide, it also takes away the exercise effect. So they've identified a robust exercise benefit, and they've started to identify the mechanism by which exercise works. So that's a pretty powerful paper. All right, so just from the literature, I won't go into a lot more papers, but we do know this. We know that we can activate endogenous stem cells. We also know that we can have an impact on the functionality of exogenously introduced stem cells. And there's some evidence to support neurogenic benefits of exercise. Clearly, myogenic benefits in skeletal muscle, that's sort of where we all think of exercise having its effects. Angiogenic benefits, bone benefits, mitochondrial biogenesis, so improving the oxidative capacity of various cell types. And then there are lipolytic benefits, of course, that alter the fatty acid uptake as well as metabolism within adipocytes. So the real question for us in many cases is, what is the dose? And just as I gave you the example earlier, you wouldn't hand somebody a bottle of pills and say, take a few. There's a dose written on that bottle, and we want to know what it is for exercise. So there's a lot of factors that are that complicate this, right? And you could apply this figure not only to exercise, frankly, you could also apply it to a device or a drug or any other form of treatment, a nutritional intervention and so forth. But the bottom line is we have a lot of non-modifiable factors, we have a lot of modifiable factors which impact our phenotype, which impacts whether or not we respond well or do not respond well to whatever the treatment is. In this case, the treatment is exercise training. We want to know what mode of exercise, at what intensity, duration, and frequency will give us the greatest benefit downstream. Okay? And we may provide, and I'll show you some data, we can provide the exact same stimulus to a large cohort of individuals, and we're not going to get a homogeneous outcome. Some people are going to respond really well, and some are not going to respond quite as well. And so we can work our way backwards from down here. If our end game is to reduce vascular resistance, as an example, and we train people for a number of weeks, and we find that, hey, these people responded extremely well based on that outcome, these others less well. We start to work backwards and try to figure out what was predictive of that response. So let's just talk about aging as one sort of set of experiments. So we've done a lot of aging work, and in this case, the thing that we're most interested in is restoring muscle mass and muscle function. So I kind of call it muscle regrowth in older adults who have suffered atrophy, and you can see clearly the atrophy phenotype, young female, older female, same BMI. And this is an MRI cross-section. Many of you have seen them, but gray is muscle. The foot is pointing out toward you into the room. So this is the mid-thigh region. White is fat and scar tissue, and obviously that's the femur. So young female, older female, you can see substantial atrophy as well as the accumulation not only of subcutaneous fat, but intermuscular fat as well. Young male, older male, same thing, same BMI. So I've shown this slide for years, probably over a decade, and the more I show it, the more I realize that for me to try to maintain a BMI that I once had at a younger age is not the same as it once was, right? So it's important to understand what's on the inside. But this is what we're interested in. How closely can we come to taking this muscle phenotype and recreating that muscle phenotype? We're never going to fully get there, but I think there's an opportunity to get at least part of the way there. So we want to prevent device usage. And one of the, some of you in the room know this, some of you may not, but there are two primary reasons why people end up in a dependent living setting. One is cognitive dysfunction, but the other is physical dysfunction. And many people who end up in a dependent setting, it's the consequence of the inability to actually move their own body weight. So physical function is critical to the older adult, and much of that is driven by how much muscle they have. So I'm going to show you some histology, sort of take some of you back to your undergraduate days and or medical school days where you saw this in textbooks and on slides. Just to very quickly sort of orient you to what you'll see, we look at three primary fiber types in human muscle. So there's type 1, which will stain copper in our hands, 2As, which are sort of these fast twitch oxidative fibers, and they stain green, and then the 2X fibers, which are highly fatigable and are frankly not used very often. They're only used when you're asking a muscle to recruit all of its available motor units. Those are black or very dark in our hands the way we identify them. So what happens across aging? If you just use a DEXA-based assessment of skeletal muscle, then our data sort of fall in line with the general concept that is sort of become a dogma in the aging field, and that is age-related muscle atrophy doesn't begin until the 5th decade. Okay, so fair enough. If you're looking at DEXA, you can look at someone and say, you know, when you approach the 5th decade, you need to start worrying about age-related muscle atrophy and dysfunction. But if you actually get tissue and you look at the muscle itself, type 2 atrophy is profound, and it begins in the 3rd decade. Okay? So it's not enough, in my view, to look at a relatively gross measure, which is DEXA. When we look at functional changes in that same cohort of about 220 folks, again, if we focus on the red line, and that's our strength measure, we would support the general sort of concept that functional changes with aging are mostly in the 5th decade and beyond, right? Because strength isn't changing a whole lot. But if we look at power, this is the ability to develop force very rapidly, prevent a potential fall, get up and down stairs, and so forth. Now you see a precipitous decline in power that actually mimics the decline in type 2 fiber size quite well. Okay? All right, so first thing I'll tell you is that aging is myogenic. Or excuse me, exercise is myogenic. And we've shown this in a number of studies. I'll show you one real quickly. So in a clinical trial that lasted, actually for each individual participant, it lasted a year. What we did is we trained people 3 days a week, intensive resistance training, 70 participants, 39 young, 31 old. And by old, these were 60 to 75. So the comparator was 20 to 35-year-olds versus 60 to 75-year-olds. And what we were interested in is whether or not the old muscle could respond as well as the young. That was sort of question number one. Question number two was, assuming we got an exercise training benefit, could we maintain it on a reduced volume type prescription? So we tested 2 different doses of reduced volume training, and then we actually had a group that did nothing or detrained. Okay? So the outcomes, and I'm going to just summarize it very quickly for you. Is exercise myogenic? Yes. The untrained young are shown here. This is the mean. This is the 95% confidence interval. This is DEXA. So if we look at DEXA-based thigh muscle mass, we almost, in 4 months' time, almost restored the muscle mass to the levels of young in the older adults. But if we look at the fibers themselves, and particularly the type 2 fibers, which very much suffer atrophy of aging, we restore type 2 fiber size in 4 months. So we're talking about 2 groups of people that are different in age by nearly 40 years. And in 4 months' time, we restore the size of the type 2 fibers. The reason why this bar does not reach the 95% confidence interval in 4 months is because not only have older adults lost the size of their individual fibers, they've gotten smaller, but they've also lost motor unit, total fiber number, because some of the motor units have been lost as well. So the muscle mass is smaller for 2 reasons. We can only actually approach one of those 2 reasons with a treatment. All right, what about performance? On the left you see strength, on the right is power. We restore both of those pretty well in 4 months' time. So I think it's pretty safe to say that exercise, particularly intensive progressive resistance training, is a myogenic stimulus. But one of the things that's important to point out is it's not uniform. So I mentioned this idea of heterogeneity and just want to pursue this concept with you. If we look at the individuals and how well they regrew their muscle, and particularly in this case their fiber size, we find one group that responds extremely well, and we call them extreme responders. 33% of that group are young adults, 17% of them are old, and males and females are in both. When you look at the literature and you look at any study that is trying to induce a change in the size of individual muscle fibers, you'll find that there's a mean change that's pretty much standard across most studies of a 12 to 20 week duration. And that's this group. So if you look at the average, we're about there too. So our intervention is really nothing special. It's progressive training and it's intensive, but it's nothing special. Other research teams are doing it in much the same way, and they're getting this mean right here. But what we're interested in is this extreme and this extreme. And unfortunately, even though I showed you that exercise is myogenic based on this, very nicely, on average, we still have 38% of the older adults that end up down here in what we call the non-responder group. So the 62% that did respond, either here or here, sort of carried the day, right? So we started to explore that a bit. I won't get into a lot of detail, but there are 2 processes that we became very interested in. One is how well can these people at the fiber level, at the cellular level, how well can they turn on protein synthesis, and then how well can they activate stem cells in the muscle. And essentially we think that both of those are important over the course of trying to create or restore these very large fibers. So we published a number of papers over the years, and essentially what we found is that both processes are important. Turning on protein synthesis matters, activating stem cells, and therefore having a pool of cells that can donate nuclei to these fibers as they grow. Both of those are very important processes, because the people that didn't respond were unable to do either one. And the people who responded in sort of that extreme cohort did both very, very well. So we then sort of can conclude from those studies, non-responders cannot turn on protein synthesis very well, and they certainly don't activate their stem cell pool. The modest responders, sort of that middle average group, they have a little bit of translational signaling upregulated, which is the protein synthesis machine, and they do add a few nuclei from their stem cell pool. But these people who are extreme, very robust responses. So what makes them unique? What makes them different? We did some microarray to try to get at that, and what we really found from this is that there's a sort of a hyperinflammatory gene expression profile in the people that are non-responders. And these are untrained sedentary muscle samples, people walking around with sort of a hyperinflammatory state in the muscle. Whereas those that end up being extremely responsive to the treatment, they're walking around with an expression profile where they're primed. This is sort of what I call being primed to respond. They're primed for ribosome biogenesis, so making more ribosomes, so the protein synthesis machinery is upregulated even in the resting muscle. They're primed for mechanosensing based on a gene expression profile that suggests that when you stimulate someone in the rehab setting or in the exercise setting, you activate that muscle mass, you mechanically load it, they have an upregulated ability to respond to that from a sensing standpoint, and they have more stem cells. So one of the most compelling findings in this whole project to me was that this group walked around with more satellite cells or more muscle stem cells than the rest of them before they started training. Okay, so they just happened to have more. Those are some of the key differences that came from that. So I'm an optimist when it comes to exercise training, and I'm absolutely not convinced that a non-responder is a non-responder forever. I think what we need to do with that person is figure out the better prescription for them. Okay? So they were a non-responder to 3 days per week high-intensity training. Maybe that was not the right stimulus for those people. So we did a 4-arm randomized trial which followed the previous, and this time we focused on the older adult. That was our interest anyway. The first study was all about the young group as just a comparator, but this is primarily focused on optimizing a prescriptive dose of resistance training for the aging, atrophied older adult. So it was 4 arms, 4 different prescriptions, and we trained these folks for 35 weeks' time. The idea is we'll go long enough, we'll start to see differential effects. And just for those of you who have not done work in this area, I'll jump to this and go back. This is sort of what you deal with when you're trying to do a clinical trial involving a behavioral intervention like exercise training, which requires a lot of effort, a lot of time dedicated. The participants are highly dedicated and motivated individuals. They're traveling to and from UAB 3 days per week. They're fighting their way through the hospital parking decks, getting to the exercise facility, committing their time and effort there, going back every few weeks, providing samples, doing rigorous testing. There's a lot that goes into it. And in fact, I always like to compare and contrast these types of trials to drug trials. In drug trials, there is a means of monitoring whether or not an individual is taking the medication. There's a means of doing frequent evaluation, whether it be every 6 weeks, every 12 weeks, what have you. But the bottom line is there's not dedicated 3 days per week, 50 to 90-minute interaction that requires dedication on both the research team side as well as the participant side. So these are tough studies to do. And what you'll see from this is that from 624 interested older adults, we ended up studying 64. Or completing data analysis on 64 is about 10 to 1. But you can see that most of what happens in that initial phone screen is that we screen a bunch of them out. Once we get them consented, it's about 2 to 1 from consent to completion. And the reason for that, if you've done these types of studies, is you well know, after consent, you're still doing screening. So many of them are lost during screening after consent. Okay, so 127 provide consent. We lose some on our GXTs. We lose some on physical exam, and so forth. We lose some because they're non-compliant. Those are the types of things that happen. But if you can navigate through all of this and eventually get these people enrolled in your randomized trial, they stick with you. They're very dedicated. And so what we did is 4 weeks of what we called pre-training. It was a familiarization period to sort of get them ramped up. And after 4 weeks of pre-training, a lot of testing, and then introduced this randomization to 1 of 4 doses. So the concept was pretty straightforward. We wanted to study or identify which program we thought was optimal for the older adult. So these letters represent either high or low intensity, and the number of those letters represents how many days a week. So HHH3 trained Monday, Wednesday, Friday, high intensity every day. HLH trained high, low, high, Monday, Wednesday, Friday. HH is a Monday, Friday, 2 days per week prescription, and then HL is Monday high, Friday low with Wednesdays off. So 2 programs twice a week, 2 programs 3 times a week, and we introduced what we call sort of a low intensity day, thinking that, frankly, our concept was that the previous study, the young versus old comparison, was this program. We thought for the older adult, based on some of our stem cell work and some of our sort of regeneration and recovery work in the lab, we thought that was too frequent. We said, well, but they need more time off, so we'll give them a low day in between and or nothing in between. So we thought that these 2 prescriptions would be optimal for restoring muscle mass. And beyond that, we thought that this one would supersede all others when it came to functional outcomes such as power development and so forth. Because on those low days, they actually trained with low loads, but did it very explosively. We had them moving fast. And the idea there was to develop some burst power, some short-acting muscle power on the low day without really causing a lot of delayed onset soreness or fatigue to the muscle groups. All right, so that's what we did. In the end, sometimes hypotheses work out, sometimes they don't. This worked out pretty well on some of the outcomes. So when we look at the DEXA-based measurement of how much muscle mass we restored, okay, HLH did by far and away the best. The other two programs, HH and HHH, which each had at least twice a week of heavy loading, did really well as well. But they introduced about half the muscle regrowth of HLH. And then the HL program, which we hypothesized wouldn't do much, it really didn't do much. So 1 day a week of high intensity loading was not sufficient to do a whole lot. When we look at the fiber level, the picture's a little bit more murky, but the bottom line is all three of these realized hypertrophy, and this one did not. So it sort of fits. The one thing, the way this is, just to orient you, from just that 4 weeks of pre-training, we got some fiber hypertrophy. And then beyond, once we randomized them to their prescriptions for the next 30 weeks, that's when we got the differences where these guys didn't move any further. Okay. And in terms of strength outcomes, you see the same pattern. 4-week gains in strength while everybody was on the same familiarization program or pre-training program. And then beyond that, we start to see that the HL group doesn't quite do as well as the others. HLH, at least on isometric strength, does better than the others. Okay. All right, so even though we gave 4 doses, one sort of seems to emerge as maybe ideal. There's still inter-individual heterogeneity, and it's worth pointing that out. So based on thigh muscle mass, look at this. HLH, these are individual people. How much thigh muscle mass they gain. I don't have the units, or excuse me, I don't have the individual numbers of people down here, but these are the units in grams of thigh muscle mass in terms of change. So, really, really high responders, some modest responders. And the good news is on HLH, there's not a whole lot in the non-responder region. And you can kind of step through these programs. HL, which is the least effective, lots of people doing nothing. Only a couple people over here that are modest, but you still see a nice spread. So we became interested in that, and I won't, this is some of Mike Steck's work. I don't want to go too deep into this because I do want to touch on Parkinson's. But let me just say, when you take those people and just look at the first 4 weeks of how well they respond, you have a number of people who respond well to just that early pre-training period and those who don't. And so we took that and kind of dove in, and Mike dove in quite deep. And what we discovered from that, I'll summarize it quickly, the ability to activate the protein synthesis machinery, and particularly create or make new ribosomes to support protein synthesis, was clearly one of the factors that drove the difference between those who were extreme responders and those who were non-responders. And he did that at the level of some of the signaling that directs protein synthesis machinery. And then he went a step further and said, you know, does this also imply that if those individuals are in the extreme cohort, do they need to add nuclei along the way to support this? Yes?
Quick question.
Yeah.
Can you define for us what compromises high intensity versus lower intensity work?
Yeah, so high intensity, if you're familiar with kind of percentages of repetition maximum, high intensity in our hands is people who reach voluntary failure or volitional fatigue within an 8 to 12 repetition range per set. What we did on the low days was whatever that load was on the high day, we reduced it 30%. Okay, and then they did it rapidly as opposed to high loads, it was all about speed. Anyway, so these people added nuclei quite well. So this mimicked the previous study in terms of some of the things that differentiate these people on the extreme ends. We went into cells and showed some, I think, with Gina Meni, who's here as well, showed some interesting data that essentially, if you block the ability to make new ribosomes, even at the cellular level, that results in the inability for these tube-like structures, which we do in culture, to grow. Okay, so HL2 is totally ineffective in the older adult. HLH3 seems to be the best program, at least to try to restore the muscle mass that we were most interested in, which was the ambulatory and anti-gravity thigh muscles, particularly the quadriceps. But there is a lot of heterogeneity, and so that's just sort of food for thought as you design your own studies. We've got to take into account this heterogeneous adaptation. Okay, sample sizes have to be quite big. So I've got a few minutes. I do want to touch on Parkinson's. We started studying Parkinson's about 4 years ago. Most of you in the room probably know a little bit about this neurodegenerative disease, But one of the things that piqued our interest in it is it's an age-related disease. So 95% of individuals are diagnosed after 50. They have many of the same age-related neuromuscular changes of non-Parkinson's older adults. But in addition to that, obviously, with this deterioration, okay, of dopaminergic neurons in this part of the midbrain called the substantia nigra, they have a number of changes that are classic motor changes, so bradykinesia, resting tremor, rigidity, instability, but then also a number of non-motor changes, such as they start to lose their ability to smell, they have cognitive dysfunction, some of them get quite depressed. There's a number of non-motor symptoms as well. So we became interested in this group, and we formed an interdisciplinary team to study them and intervene on them with exercise. And one of the things that got us really interested was the fact that they have, and it's been shown in a number of human studies, sort of a relatively ubiquitous dysfunction of mitochondria that's been shown in the blood, it's been shown in postmortem brain, it's been shown in skeletal muscle biopsy, and it's particularly, it seems to be focused on both complex 1 and complex 4 in the mitochondrial electron transport chain. So we became interested in that because we feel like exercise of a sufficient intensity we know has a dramatic impact on mitochondrial function, and we thought maybe that would carry forward into a functional study. So this was a pilot, the first paper anyway, by Neil with an interdisciplinary team, and this actually started when Ray Watts was the dean, and so this was a group that really was behind this from the get-go, and it was a good time doing it. Exercise, just as we've shown in the aging adult, exercise is myogenic in Parkinson's as well. And they do have age-related atrophy at the beginning. Here's young, here's Parkinson's at the beginning. We more than restored fiber size in these individuals. We also restored function pretty well, strength on the left, power on the right. And in addition to that, because this stimulus was not only resistance training, we also introduced some interval exercise to try to stimulate cardiorespiratory adaptation along the way, some metabolic adaptation along the way. We also looked at the muscle for biomarkers of whether or not we were having an impact on the muscle's ability to undergo oxidative metabolism and receive blood flow and so forth. So we show exercise as angiogenic. So Neil and Kelly did a lot of these studies where we're looking at the number of capillaries that contact individual fibers, and we restore that to the levels of young, okay, in the type 2 fiber. When we look at mitochondrial function, I'll just summarize it in one figure. Yes, they have a mitochondrial dysfunction, and now this is not the mean of young, this is actually the mean of age-matched, okay? And this was important because we want to know, is what we see in the Parkinson's muscle any different from normal aging? And for some of the outcomes, actually, there was no difference between Parkinson's and normal aging. I'm pulling out what's called subsarcolemmal complex 4 activity, and the bottom line is there's a tendency for it to be lower than age-matched young, but it's a robust improvement with 16 weeks of intervention. So then the last bit of data I want to show you is, and this is really kind of where exercise needs to go. Particularly in, not only in neurodegenerative disease, but beyond this, in mild cognitive impairment, in a number of key areas. We need to understand how neurogenic is exercise. So one of our outcomes of interest is very simple, and that is we test motor unit activity by surface EMG of the quadriceps during a sit-to-stand. And by knowing what that motor unit activity pattern looks like when the muscle contracts maximally, we can then determine how much of maximum motor unit activity is required to do something as simple as stand up. And you can see young people before and after resistance training, older adults, and then those in the Parkinson's study. You can see there's a robust difference between normal aging and Parkinson's in how much motor unit activity is required just to stand up. We think a lot of that is aberrant activity. It's not necessarily contributing at all to the movement itself because their muscle mass is the same as their age-matched peers. But the point is, with training, you get a very nice reduction, and this is interpreted as an easing of the movement. It's much less physiologically difficult. There's less motor unit activity required just to go from sitting to standing. Okay? Happens in everybody, but most importantly, in those with Parkinson's, after 16 weeks, they actually start to look like age-matched untrained folks. All right, but then if we dig into the brain, and this is Kimberly Wood's data, very preliminary data, but just want to point out, if you look at brain activity as assessed by blood flow to regions of the brain, we wanted to know, what does our high-intensity exercise bout do to the brain in individuals with Parkinson's? So this is very preliminary, but we basically had individuals be scanned in the resting state, then come down, do one bout of exercise using the same paradigm. 1 hour later, go back upstairs and be scanned again. And what we find is that the prefrontal cortex, both the ventromedial and dorsolateral regions, light up quite nicely, indicating more brain blood flow. When we move into the brainstem, the midbrain, excuse me, nice upregulation again. And when we move into kind of the region where where Parkinson's originates or is most focused in the substantia nigra, again, a nice upregulation in brain blood flow. Very preliminary, but is at least some indication that we're delivering nutrients, we're delivering oxygen, we're delivering more blood to some of the regions of the brain that are critically important for both motor and non-motor functions in Parkinson's. Over time, the biggest question is, are these regions of the brain actually adapting with training? And so that's the current study that's underway that Kimberly and Amy Amar are directing, and essentially we're looking at 16 weeks of intensive training with scans like this, as well as more scans to study brain metabolism both before and after training. So from a clinical standpoint, high-intensity training improves a number of outcomes. For those of you who maybe clinically test or deal with individuals with Parkinson's, the UPDRS, the Unified Parkinson's Disease Rating Scale, changes in these indices of function, sections 1, 2, 3, and 4, toward the better, meaning the numbers are in this case, looking at motor, for example, numbers getting lower means improvement. So in 4 months' time, we're seeing a number of improvements, not only in UPDRS, but in the Parkinson's disease quality of life scale as well. So I think there's some evidence, and I think this is at least one step for us toward the desire to move toward exercise dosing studies in Parkinson's to just see what is the threshold of exercise training required to be truly myogenic, angiogenic, neurogenic, and so forth. We want to know if it's neurogenic, and I'm not here to tell you that it is. We're hopeful, but we think we have some encouraging data to suggest that it may well be a neurogenic stimulus. So I've sort of flown through a lot of data. I think I've got about 7 or 8 minutes left. I won't go into a lot of detail. You heard in the introduction that we do have a national network to take some of this to a larger scale. So any of you who are interested in large-scale trials involving exercise, I'd love to talk with you about partners that might be logical partners for your particular disease of interest or your particular efforts. But the National Exercise Clinical Trials Network is actually 61 now, so this slide is a bit out of date. But the bottom line is it's a nationwide group of people highly motivated and interested with the expertise to do these large-scale trials. Those are some of the institutions there. Okay. We have a steering committee or an executive group, and you can see some of you probably recognize some of these people as leaders in this particular field. The other thing I want to point out very quickly is that we just got this new center. So this is a National Resource Center which we brought to UAB, and we will have a pilot grants program. RFAs will be coming out hopefully soon after the new year. But it will be available not only for UAB investigators, but for investigators across the country, with the idea that people will begin to form teams. They'll begin to develop multi-center trials. We'll provide them with some pilot data, as well as some consultative service, some infrastructure support, some core lab access, things of those sort of critical needs for individuals to move from where they are today. Perhaps they're doing studies on 40 or 50 people at their institution today, and maybe they think the next step requires 400 to 500 people. Okay, we want to sort of help them with the design of that trial and actually help them pull it off. So that's a resource that's coming. And then for any of you who train pre or postdocs, or you have the desire to train pre or postdocs, we do have a training program, and some of the trainees are here today. We'll be recruiting this spring 1 or 2 pre-docs and at least 2 to 3 postdocs for for this program. So I'm going to stop there and take some questions. Thanks.
Your study, your studies focus on resistance training. Did you anticipate a similar effect with aerobic training?
Well, the outcomes are different in terms of what the desired outcomes are different. But in terms of heterogeneity, yes. So there's a heterogeneous adaptation to endurance training as well. We were focused on resistance because in these two populations, we were dealing with people who had suffered age-related atrophy, and in our mind, that's the best mode to regrow sort of lost or atrophied muscle. The reason why we combined resistance with interval training for the Parkinson's is because not only did they have a muscle mass deficit, they also have sort of a fatigue issue and an endurance deficit, which we thought was largely mitochondrially driven. So we thought, we'll introduce that. But your point is well taken. That's part of the dosing, right? What are the things in a given population that we're trying to improve on, right? What are the deficits? What are the consequences, frankly, of either the disease process or the treatments for that disease that have an impact on function? And then design the program that best meets that, or best will attack those things. So, and I gave that example of disease primary process or treatment, because if you think about cancer therapy, for example, cancer survivors have significant muscle atrophy. And it's not so much the cancer as it is radiation and chemotherapy and malnutrition. So those are individuals that would probably benefit from more of a resistance training type program. But you can identify a number of populations where endurance training might be the bias. At the end of the day, we should all do both. But from a sort of an evidence-based medicine approach, I think the best place to start is identify your primary outcome of interest, and based on today's science, which mode of exercise can best counter that or improve on that, and go with it. I think designs become much more complex when you start having combined training programs. Multiple doses of all these things get pretty complex. Yes?
I was interested in your cerebrovascular changes there in Parkinson's disease. How did those compare with age-similar healthy subjects? Do you have any idea?
I do not. This acute bout of exercise we only did in Parkinson's, so I don't know the answer. It would be important to know. I suspect that if you take, and these were not screened for MCI either. So these were stage 2, 3 Parkinson's, some of them with some mild cognitive impairment, some without. I think if you took a mixed bag of older adults, MCI and not, you'd probably see a very similar induction. For us, it was just encouraging. Where it goes from here, there's a lot that has to be done.
You remind me, by the way, a recent book by Norman Deutsch. I wonder if you know of it, The Brain That Changes Itself, something like that. It's a popular book. Like chapter 2 or 3 is on Parkinson's disease and exercise, and the author speaks with a guy who's just really held back in activity by his Parkinson's disease. And he just says, I'm going to just keep walking. And he just kept feeling more and more improved, and started to advocate this in South Africa where he lived. And the Parkinson's Disease Society there kept saying, don't talk about this. No, you're going to make people worse, and so forth. And he goes, no. And he learned his optimal dose. He learned not to overdo it. But he insists that his symptoms really would come down just through regular long-distance walking, basically, but was shouted down nonetheless by the professional society.
It's interesting, you know, so our experience, which is fairly limited in Parkinson's, but even with the individuals that we have studied, they come in with varying patterns of physical activity. The only restriction we had was that they were not resistance trained. So some of them were swimmers, some of them were walkers, you know, there was a variety. But every one of them that did any form of exercise touted the benefits. And in some cases, you know, you'd hear from a regular swimmer that their tremor subsides for 2 to 3 hours after each swim. So it becomes a daily habit for them. Or you hear from somebody else who you know, does some more challenging walking, brisk walking and or walking with challenges introduced, that their symptoms subside. We decided to really start at the top with very high intensity training. One of our questions, frankly, was can older adults with Parkinson's disease, stage 2 or 3 Parkinson's, actually tolerate it, right? That was number one. It's sort of like any other progression of a treatment. What's the phase 1? Safety, tolerability, etc. Then you go to phase 2. So this was sort of phase 1. But it turns out they not only tolerated it, they embraced it. You know, and we've got some of the people in this room who are actually trainers in that study, and I think they would agree that these individuals with Parkinson's, when it came to their 16-week post-training test time, most of them were pretty sad about it. They really enjoyed it. Yes?
So with your patients that are semi-cynical in some of the training, were they on a special diet or if they were able to eat whatever?
No diet. The only thing we do in that regard is monitor. So they do fill out 4-day diet records, and we do that at the beginning and the end. So we have some idea of their caloric intake. We're interested in protein intake and nutrient intake, total caloric intake, and so forth. So we sort of document them, but there's no guidance other than trying to get them to fill out a 4-day record accurately. And in the end, what we find, well, number one, somebody's laughing in the back. I think we've all experienced this. Most people underreport, right? So the older adults that we've studied, on average, are reporting to us about 1,850 calories a day. Probably 200 to 400 calories under, most likely. But at least we're getting what we think is a pretty good distribution of what we really care about, which is protein intake, branched chain amino acid intake, and some of the micronutrients. Yes?
So this goes back to your research in micrograph. So some patients that we see here are too weak to lift their arms from either a combination of neurologic damage from stroke or spinal cord injury or just muscle atrophy over time. And so in therapy, sometimes we try to partially eliminate gravity by just a device called a Swedish sling. We use counterweights. And I just wondered, is the exercises that we do in that setting different from typical resistance training, and should we alter our regimens now?
Well, I think going into any exercise treatment, when I talk about dosing and when we start to define what we think the thresholds are for adaptation, it's all relative, right? So if we say 75 to 80% of maximum is required to get X adaptation, that applies to everyone, even that individual who can barely lift their arm, right? So I don't want to beat around the bush, but the bottom line is, in my view, the muscles will adapt if they're operating at a percentage of maximum that we think is a threshold. I can't tell you specifically what that is. It's going to depend on what adaptation you want, right? But I think if we can identify that threshold, that's going to be critical. If you have an individual who cannot, frankly, move their limb, you can accomplish that with electrical stimulation. You can mimic exercise, and you can do it safely. And we've got some individuals in the room who've done that and do it regularly, actually, in spinal cord injured individuals, for example. So there are ways to actually do relatively high intensity resistance training in spinal cord injured individuals with E-stim. Scott Bickel does that a lot. Jaren Yarar in the back has done that a fair amount. In fact, we did a training study and showed that we could hypertrophy muscle doing that. So, you know, there are going to be instances where sort of combined therapies are needed, right, to achieve this sort of exercise outcome. Any more? Okay, thanks.